Recording in progress.
Hello everyone, welcome to today's webinar session. I am Abhishek Gupta, Maxim of Fun Pharma Division welcomes you all for this scientific session. Today with us we have Dr. Rajesh Varnakar, an eminent speaker and a chest physician from Nagpur. And also we have with us Dr. Avinash Gandhare, chest physician from Nagpur. Welcome you all. Welcome sir. Welcome Rajesh sir. Welcome Avinash sir. And welcome all the audience who are present in this time for the session. I hand over the session to Dr. Avinash Gandhare for next proceeding for the sessions. Over to you, sir.
Hi. Thank you. Hello everyone, and welcome to the today interesting session on the modern day management of allergic rhinitis and the asthma. Let me now welcome and introduce our speaker, the man who doesn't need any introduction. He is well known among all of us for his knowledge and contribution in the field of pulmonology. Dr. Rajesh Varnakar sir, he is director and consultant pulmonologist at Gateway Hospital and Research Center Nagpur. He is National Secretary of Indian Chest Society. He has more than 34 national and international publications. He is a principal investigator in many asthma, COPD, and pneumonia trials. He has presented many research papers in national and international conferences. He is recognized PG guide in the respiratory medicine. He is MD and DNB examiner also. He is a national editorial in the Lung India Journal, and he has many contributions. He is an advisory board of Respiratory Research Network in India. So I welcome Dr. Rajesh Varnakar sir without wasting that much time, and let's begin the today's interesting session. Thank you.
Okay, thank you Avinash for your kind introduction, and thank you Abhishek for initiating the session on this very important topic. I'll just share my presentation. Okay, so here we begin. So we are here to dwell on the topic which has been given to me to discuss today with all of your esteemed audience who have joined, is modern day management of allergic rhinitis and asthma, which is a very common condition that coexists and we see in our daily practice, and the role of the combination of histamine and a leukotriene receptor antagonist in treating this condition. So we all know the burden of asthma and allergic rhinitis when it's put together. If we just talk about asthma alone, there is an estimated 300 million people worldwide who have asthma, with about 37.9 million in India, so it's fourth largest case burden of asthma in the world. But we unfortunately top the cases of death in asthma all over the world. So although we are fourth in prevalence of asthma, the mortality due to asthma is the largest in the world in India, and the total population of 55% of UK population, equivalent to that, we have asthma prevalence in India. This is actually a latest study which was published in Lancet in 2020, and there was an Indian study which reported that prevalence of allergic rhinitis was about 11%, more than 11% in children who are aged 6 to 7 years, and about 25% in children aged 13 to 14 years. So this means that worldwide, India has one of the highest concentration of air pollution. You know that unfortunately the 20 most polluted cities in the world, about of them, about 13 are from India, and Delhi has got dubious distinction of the most polluted city in the world. And this pollution itself is caused by burning of biomass fuels, fossil fuels, because our thermal power stations which generate electricity are coal fed. Thermal power station, which is the most polluted way of producing electricity. And of course, we are overwhelmed with every year, new and new vehicles are being added on the roads, which is of course causing vehicular exhaust and of resultant population. Besides, there is also role of indoor air pollution, which is there because of use of mosquito coils, increase in poop and sticks, and all those things that we just factor in. And all this has led to exacerbation of allergic rhinitis and asthma in the country. So if we take the data of world, in fact, there is no doubt that there is increasing trends in the prevalence of inflammatory diseases, widely asthma and allergic rhinitis. And if you see the study, which was about 8 or 9 years back, we see a very steady graph growing from the year 1960 to the year 2000. And there's a steady increase in this prevalence of this condition put together. So if we say that approximately about 10 to 30% of adults and 40% of children are affected globally as per the data that we see now, it is found that more than 40% of patients with allergic rhinitis have asthma, and more than 80% of people with asthma also have allergic rhinitis. So there is a coexisting of this condition. So if suppose a patient has allergic rhinitis, there is 40% chance that he also has asthma. While in patients of asthma, 80% of the people, if you just look for allergic rhinitis, it will be coexistent also present. So what is the relationship between asthma and allergic rhinitis? It is also called as what we call United Airway Disease or common airway disease because of the epithelium that they share. And what happens is that there's inflammatory mediators which can reach even the lower airway from the upper airway through the airway passage because it's not connected. And they might also be able to reach the lowest airways to the blood. And a number of these mediators, as we all know, that histamine, cystine, and leukotrienes, and some cytokines, have the ability to spill over into the system of circulation. So allergic rhinitis is, of course, a very definitive risk factor for asthma. And we see this is the study which was published, which says that allergic rhinitis increase the risk of asthma to about threefold, as we see that it is 3.6% in just people who don't have allergic rhinitis at the baseline, but almost rises to 10.5 times if we find that in these asthma patients who at the age of 23 had asthma, they had a baseline allergic rhinitis to actually begin with. So how do we classify the etiological classification of rhinitis? Can be based on the mechanism that it is caused. For example, you have IgE, H-mediated allergic rhinitis, which is IgE-mediated inflammation of the nasal mucosa, which results in eosinophilic and Th2 cell infiltration of the nasal lining. And this can be further clinically classified into intermittent or persistent, that we will see later. It can be classified into autonomic cause, which can be also vasomotor rhinitis. It can be caused by drug-induced, as we know, rhinitis medicamentosa. Hypothyroidism, hormonal. It can be infectious after a bout of viral, as we all know. It can be bacterial and fungal infection, as we have seen this post-pandemic or post-COVID infection. And in some cases, it can be idiopathic. So what is the pathogenesis of allergic rhinitis? Let's touch the base on this. And this disorder is actually, as we all know, is initiated by an allergic immune response to an inhaled offending allergen. The atopic individuals who are allergic to this particular allergens have a genetic predisposition to become sensitized to harmless allergens via activation of dendritic cells and T lymphocytes. These dendritic cells actually capture these allergens and act as an antigen-presenting cells, thereby presenting the allergenic peptide to T lymphocytes in draining lymph nodes. When allergens are deposited onto nasal mucosa, they bind to allergen-specific IgE on the surface of mast cells, and this causes rapid release of preformed mediators such as histamine, leukotrienes, prostaglandins, which can cause symptoms, and these symptoms can be immediate reaction, like patient starts to sneeze, has itching, has got running nose, has blocked nose, and may also have late phase reaction later on. So we know that the common triggers of allergic rhinitis, which we test in our skin prick test, are pollens from trees, grasses, and weeds. Very important. Dust mites are very common allergens that we see, and these patients typically have a lot of sneezing when they just get up from the bed because the dust mite present in their bed. Molds is another, and in animals, the dog and cat also dander. And there is a subset of patients who have allergic rhinitis because of the occupation they are associated with. And it can be anything, occupation involving floor, latex, laboratory animals, wood dust enzymes, and airborne proteins. So what are the clinical symptoms of allergic rhinitis? Very simple. I mean, you have patients who complain of nasal itching, sneezing, rhinorrhea, nasal obstruction. Sometimes they also complain of hyposmia. And this is a typical allergic march that starts from eyes. In fact, so you have ocular symptoms, eye itching, red eyes, and also genital infections, swollen eyes. And later it can come to mouth, so the allergic march then can reach the oral mucosa, and hence you have oral and pharyngeal itch. And really it can take shape of angioedema of lips, mucosa, soft palate, or also pharynx. And all these symptoms certainly affect your lifestyles, and hence you have got sleep disorders, emotional problems, you feel fatigued, you're not in mood to work. And the symptoms can also extend to ears, sinuses, and lungs, leading to sinusitis, blocked ear tubes, and of course, asthma. So allergic rhinitis, according to symptom duration and severity, as I said, can be classified as per the area guidelines, that is allergic rhinitis impact on asthma guidelines. And this is actually clinically, we can classify it into intermittent, mild, moderate to severe, and persistent based on duration of symptoms the patient has. So why it is important to get rhinitis under control is because people with allergic rhinitis are 4 times more likely to have poor asthma control. So allergic rhinitis is actually a risk factor for asthma, and as its severity increases, so does the severity of asthma. So the patients with both allergic rhinitis and asthma who have both coexistent condition, it has been found that they go to the doctors more often, they get hospitalized more often, and hence there is an increased cost of asthma-related drugs and the hospitalization cost that it causes. And therefore, poorly controlled allergic rhinitis impairs asthma control. And it is a well-known fact in various studies that people with severe rhinitis are over 4 times more likely to have poor asthma control. It's important to recognize this condition and treat them individually and also combined ways so that both the condition are kept under control. So for diagnosis, for also recognizing, we need to have a correct diagnosis, and it is very important that patients, we know that patients with allergic rhinitis and non-allergic rhinitis may share similar symptoms. For example, sneezing, nasal congestion, rhinorrhea, and nasal itching. Actually may require different treatment, and this misdiagnosis can prevent the patients from receiving the most effective clinical management. And there is also a recommendation by the area suggests that patients diagnosed with allergic rhinitis should also be evaluated for asthma. So all the patients who have allergic rhinitis, and this we should actually make aware of our also ENT colleagues, that if suppose a patient correctly diagnosed with rhinitis also benefits from being effectively treated for asthma, and hence we should test for asthma also in these patients. The symptoms associated with allergic rhinitis, such as sleeping disorders and poor mental health, may have a significant impact on the patient's quality of life. And it's very important that early and correct diagnosis can significantly improve the patient's well-being. So what are the recommendations for allergic rhinitis, and how this, basically the diagnosis recommendation test for rhinitis is just by simple eliciting the clinical history. We can assess their quality of life because these people have got a poor quality of life. And And then physical examination, which can be suggestive of allergic rhinitis. So clinical history, as we are aware, you have to ask whether the patient has got the symptoms associated with allergic rhinitis. Are these seasonal or perennial? If they are present year-round, if the patient also has got concurrent allergic conjunctivitis, which also should be treated, and if patient has got asthma, atopic dermatitis, food allergy, and other symptoms of allergy. The physical examination can include the appearance of mucosa examination of the appearance of mucosa pallor, which of course is non-specific, but we do have some patients who have got allergic shyness like dark discoloration of the periorbital skin. We got Denny Morgan lines, which are folds of the lower eyelid in children because they constantly rub the eyes. And also similarly, when we rub your nose constantly, we got a typical allergic crease, which appears as a horizontal wrinkle near the tip of the nose. And we should always rule out any absence of foreign body tumor, purulence, or also nasal polyp before we really treat them as case of allergic rhinitis. Recommended tests are basically, there is no gold standard, but standard allergen sensitization test is used in allergic rhinitis, and this can be done by doing it in the blood, which is specific IgE blood test, or a skin prick test with aeroallergens, which is commonly done to diagnose the atopic patients. Allergic sensitization testing in primary care should be carried out using an in vitro IgE testing. There are several labs which are doing then we should look for symptoms suggestive of other associated conditions such as allergic conjunctivitis, asthma, eczema, and sinusitis, and manage it accordingly, because we should remember that 80% of asthma sufferers have also concomitant rhinitis. So there is no universally accepted gold standard test to support the diagnosis of allergic rhinitis. However, there are some tests which are very difficult to perform in actually clinical, what we call a setup, but there are tests like nasal provocation test in line with what we have, what we call bronchoprovocation test. We got these nasal allergen challenges that can be done, but these are of course generally done in research studies and can be done in a specialized allergy test. So this is a diagnostic algorithm in which we classify rhinitis into allergic and non-allergic or occupational. Non-allergic rhinitis can again be subclassified into infective and also non-infective. Infective can be acute and chronic, while non-infective can be because of some other causes like immunopathological findings, Stroke syndrome, vaginous granulomatosis, sarcoidosis, structure abnormalities like you can have deviated nasal septum, we can have nasal polyps or also foreign bodies in the nose. Hormonal can be the cause, can be drug induced like oral contraceptives and rhinitis medicamentosa, and some other like also GRD, gastric reflux, atrophic rhinitis. All this has to be diagnosed before you really begin the treatment as per the diagnosis. This is a pharmacotherapy that we usually use in adults and children. So we have a diagnosis by history or with or without a skin prick test or serum specific IgE, allergen, and irritant avoidance with or without DOSHI. So the primary treatment basically can be avoidance of the allergen, which is the most effective treatment to treat allergic rhinitis and asthma. And if it is not possible, sometimes then if it is mild, then we have oral or topical non-sedating antihistamines. We can upgrade our treatment to topical nasal steroids, which is available in spray and drops for children. If there is a treatment failure, if he has got no relief, then we can use an adherence, increase the dose with or without oral corticosteroids. And even then, if he's not having any of the relief and continues to have watery of rhinorrhea, then you can add ipratropium nasal spray. If there is a itching or there is a sneeze, then you can add also orally non-sedating antihistamine. If there is a catarrh, and you can add also lipoprotein receptor antagonist. If there is a nasal blockage, you can also use a nasal decongestant. If there is still possible, you should rule out, and you can can do some regulatory studies to find out if there are some polyps or structural abnormalities. And in the end, if everything fails, you have got an option of immunotherapy if you can specify and isolate an allergen which is causing a problem in a carefully selected case. Immunotherapy can be the answer. So this is a very good study which actually assesses the physician beliefs and practices about diagnosis and assessment and treatment of coexistent disease, because the lack of awareness of this, both of course, the condition coexisting is a problem. So there was a survey which was done on physicians and what is, and survey asked the questions like the physician believes about the existence of coexistent asthma and allergic rhinitis. So asthma and allergic rhinitis can coexist and could have a specific therapeutic consequences. Most of them agreed to this. Then what about the management of coexisting asthma and allergic rhinitis? So the actually survey in this study asked that how do you manage patients with coexisting asthma and allergic rhinitis? Do you just treat only one condition, or the condition which is more troublesome, or both just simultaneously, or manage asthma on the long-term basis and allergic rhinitis just whenever there is some symptoms or breakthrough symptoms, or refer these patients to an allergens? And this study survey also included India, and most of them agreed that these two conditions are to be managed simultaneously. What about the physician's belief about patients' treatment preferences? So it was discovered that patient in the survey, in the study, that patients prefer oral medications over inhalers and nasal sprays for the asthma and allergic rhinitis, and this preference is also reflected in asthma patients when we say they are quite reluctant to use inhalers. So in the same way, we find a reluctance for using nasal spray, although these are more effective than the oral treatment, as we know about it in asthma. So these are the area guidelines. This is allergic rhinitis impact on asthma guidelines, which came in 2019 and has been modified in 2020 for adults more than 12 years, for children more than 12 years and adults. And here we use a visual analog scale, which is a psychometric instrument, which basically measures the patient's response on a scale in terms of whatever symptoms they have, whether they are not at all bothersome to the extreme point of the scale in which they are quite bothersome. And hence we have this visual analog scale, which is also used for our measurements of other chronic diseases, and then we scale them from 1 to 10. So depending on the visual analog scale score, we can start the treatment. And the first and the treatment that options that we have is oral and also nasal antihistamine tablets, oral and also nasal intranasal corticosteroids, and of course leukotriene antagonist. So depending on the visual scale, we can upgrade or downgrade the treatment as per our requirement. And hence the most common treatment that we instill in the patient is, of course, intranasal corticosteroid, which has been found to be most effective. So what we find here is that histamine is the most important mediator in the early phase reaction following an allergen nasal challenges, but it also plays a role in the later phase response, which is very important. So this nasal allergen provocation actually results in a significant increase in mediators like histamine, leukotrienes, and tachypines that we have seen earlier, and immediate nasal symptoms like blockage, rhinorrhea, sneezing, and itching. And this happens in patients with allergic rhinitis. So it is not that we should use only an agent which is got a short-term effect, because between 2 and 24 hours after allergen provocation, the late phase nasal symptoms, especially blockage, are observed in allergic rhinitis patients. And in the late phase, an increase of histamine and leukotrienes release is also observed, that we all know, and hence arachidonic acid cascade and formation of leukotrienes is very important to understand what happens. It is a bit complex, but if we can understand the cascade, it's better to know that how the treatment would actually benefit these patients. So arachidonic acid is stored in membrane-bound phospholipids and released by the action of phospholipases. And the enzymatic conversion of released arachidonic acid into biologically active derivatives proceeds through one of several routes which have been there in this cascade. The cyclooxygenase converts this arachidonic acid to unstable cyclic endoperoxidases, from which prostaglandins and thromboxane are derived. And there's a formation of the leukotrienes, powerful inflammatory lipid mediators, which is initiated by the action of the 5 lipolysis producing leukotrienes, that is LTA4. And all this basically gives rise to inflammation and pouring of fluid from also capillaries, which actually lead to all these symptoms of rhinorrhea and also later pocket of the nose. So the classification of treatment used in the allergic rhinitis is T1, T2, T3, T4, T5. So in the T1, we use non-sedating H1 antihistaminic. It can be used oral, intranasal, or ocular, or LTRA antagonist like osmotilcast. In T2, in the step 2 or in the treatment 2 step, we use intra-nasal corticosteroids. When symptoms are more severe, then we go for the step 3 of the treatment, T3, in which you can combine intranasal corticosteroids with intranasal azelastine. And of course, later, if you also want to upregulate the treatment, you can use oral corticosteroid as a short course and an add-on treatment, but don't give it for just many days. You can have a short burst of steroids to control the symptoms. And in these cases in which you have used all this and your diagnosis is correct about the allergic rhinitis you are treating, you can refer it to a specialist and who's just practicing allergy, and an option of allergen immunotherapy or biologicals can be given to these patients. So in short, this is the chart showing the treatment options for allergic that I have actually enumerated. So it's depending on which symptoms patient has got what we call a predominant symptom, whether he has got sneezing more or nasal discharge more or nasal itch or nasal obstruction or ocular symptoms, we can actually give them the respective agents to treat. And the onset of action actually depends on the molecule, and it can be from about 1 to 3 hours, and it can also begin in less than 15 minutes in also some of the intranasal or also congestion. So you have to choose the agent as per the predominant symptom that the patient presents. So now we come to the main objective of this webinar is to understand the Bellastin role, and it has been decided it's an ideal antihistamine. Basically, Bellastin is a novel second generation H1 antihistaminic, is approved for the symptomatic treatment of allergic rhinoconjunctivitis and urticaria in adults and children over 12 years of age. Bellastin has the highest number of positive attributes, like a very quicker action, quicker onset of action, and also having a very prolonged action. And these agents have been, of course, defined by this criteria as by EACI, Gallen, and also World Allergic Office guidelines. Bellastin has a favorable pharmacokinetic profile, being rapidly absorbed, resulting in an onset of clinical effect within an hour of administration, and has a long duration of action which can exceed 24 hours. And this allows this agent to be given just once daily and is quite comfortable for the patient. The route of Bellastin elimination is independent of the liver, and hence we don't see much of metabolic drug-to-drug interaction with this agent. In comparison, if you compare this molecule of Bellastin with ceftriaxone, it has got a significant greater beneficial effect on wheals and flares at the earliest post-dose measurement, as has been found in the study. And the duration of action of Bellastin has also been proven to be significantly longer than that of another very commonly used agent, fexofenadine. So these are some of the papers that are available in the public domain. for efficacy and safety of selective H1 antihistaminic versus leukotriene receptor antagonist for seasonal allergic. This was a main study that was published in 2014. It was a meta-analysis of a large number of patients, about 5,781, which established and concluded that SAH, the short-acting histamines and LTR have similar effects and safety, but short-acting histamines is more appropriate for daytime nasal symptoms, congestion, rhinorrhea, pruritus, while LTRA is better suited for nighttime symptoms, difficulty of going to sleep, and all those quality of life, which affect quality of life. And meanwhile, the dose, duration, and gender of patients may influence the anti-agent, anti-SRSH, LTRA effects. This is another study which says about management of allergic rhinitis with LDRA and versus H1 antihistamines. And this also says that LDRA, although both treatment are safe and effective in improving the quality of life in allergic rhinitis patients, the LTRAs are more effective in improving nighttime symptoms, but less effective in improving daytime nasal symptoms compared to the short-acting antihistaminics. And we know about this LTRA, which is the most prominent we have been using. We have got an extensive experience of using this molecule since of so many years. And montelukast is a selective, as you all know. It is actually a selective leukotriene receptor antagonist that inhibits the cysteine leukotriene receptor 1, and it is found, which is found in the inflammatory cells, smooth muscle cells, and endothelium in the respiratory mucosa of both the upper and lower airway, and it is used in the treatment of both allergic rhinitis and asthma, and commonly in asthma having also allergic rhinitis, because it takes control of both daytime and also nighttime symptoms. So if you is combined with what we call a molecule like Bellastin, it really gives you an ideal agent to treat and to control the patients who got allergic rhinitis and asthma coexisting, and it gives a very good effect for 24 hours. So hence, and we all know about the montelukast evidence. As we say, we have been using it since long, and so the highlight of this or what take-home message for this webinar is that there is a widespread acceptance of the existence and associated burden of coexisting asthma and allergic rhinitis. It affects the patient's quality of life and affects the control of one another condition. So both leukotriene receptor antagonists and selective H1 antihistaminics are safe and effective in improving the quality of life in allergic rhinitis patients. And this also selective H1 antihistamines are the ones who are now mainstay in the treatment for allergic rhinitis. So LTRAs are more effective in improving nighttime symptoms, but less effective in improving daytime nasal symptoms compared to the selective antihistamines. And hence they are being recommended by the guidelines. So in the end, it is said that if you treat both the condition of allergic rhinitis and asthma simultaneously, it really leads to improvement of quality of life, and also it can also prevent triggering an asthma attack. Hence, in a patient who has asthma, you should look for any coexisting allergic rhinitis, while we should make aware our ENT colleagues that if there is a patient of allergic rhinitis that comes to them, then of course we should actively investigate if the patient also has coexisting bronchial asthma. Thank you. Thank you for your patient listening.
Thank you, sir. Thanks for the nice, elaborative, and the very informative presentation. Now we can open session for question and answers. There are few questions have been came. We can take one by one. There is a question by Dr. Rajesh Sarode, which is the most potent anti-allergic amongst available drugs.
So in fact, there is no head-to-head trials, in fact, of all these antihistamines. So, because these molecules belong to what's called several pharmaceutical company. So I don't think there is a head-to-head trial among all these things, but as I said, that like selective antihistamines which are there they are quite effective, in fact. But now this Bellastin has come, and it was initially used in urticaria for these patients. And when we combined with montelukast, we got very good results. With what I call fexofenadine, there are actually studies which say that it is as effective as also cetirizine, and it is more effective than fexofenadine. So only this much data is there. But I think anything long term, if we want to give, then I think the selective antihistamines are better to use.
I think that is the best answer for this question. There is another question from Dr. Sanjay Dhanuskar. Is there any role of yoga and deep breathing exercises in preventing the disease?
Yeah, so I don't know about yoga as a specific, but yes, anything which would help is really good. But one word of caution is that I see that patients who have got stuffy nose and infective rhinitis, they start doing this what called bhastrika and inhalation exercise, which actually takes this phlegm inside. While what we ask the patient is to take some steam inhalation to just get this phlegm out of it. So I think when they're having acute symptoms of allergic rhinitis, I think doing pranayam or doing bhastrika or those kind of yoga exercise in which you take a deep inhalation inside, I think should be avoided. What is best is to go for steam inhalation. And I ask these patients who have got this chronic rhinosinusitis, who have got coexisting sinusitis with rhinitis, to go for steam inhalation, maybe a drop of what you call eucalyptus oil or something, maybe in the morning and evening. And it is our own experience that, of course, when we have got this and when we use this, we of course get a lot of relief. There are some studies, and there are also commercial packs which are available for what called nasal douching, and yes, that is one of the things that has been tried, and we have got some commercial kits available in which there is some salt which is to be used in a saline water solution, and it can be just put in the nose, or our own what we call gel neti, which some of our patients say that they of course get relief. Maybe this is same as what has been actually given the Western literature as what we call nasal douching. So there are kits available for this, but these are just what we call symptomatic relief of allergic rhinitis. They do not address the cause of it, so it can be given in acute condition when your nasal symptoms are more, and you have a lot of stuffy nose. So I think these are some of the things that we can in fact use, which is in line with yoga. Avinash, do you have any of the patients who says that? So in fact, I do tell them that actually not to do this inhalation exercise and this pranayama when they take a deep inhalation when they've got acute symptoms and their nose is actually full of yellow phlegm, because they are going to deep. They are again going to congest the sinuses, in fact.
There is also pros and cons of the yoga and exercises in asthma and allergy. So there is also a second question from Dr. Rajesh Sarode. Update on latest available test with you related to this condition and the post-COVID lung involvement. I think we want to know about post-COVID lung involvement and the allergic rhinitis. Any specific test available in this condition?
So I think we are still learning actually from this disease, but this is anecdotal experience. I don't know if there are studies, but I do see an increased hypersensitivity of the airways and including nasal airways post-COVID, because its virus has traveled, and this is a known fact that post-viral you've got hyperreactivity of the airways. So similarly, also these nasal passages are also involved whenever there is actually this COVID infection. So more so, of course, and it's our experience now post-COVID, when we see post-COVID patients that they have got problem of anosmia, hyposmia, in fact altered altered sensation of smell. They are still suffering from that, even if they have suffered COVID about 6 months back. And now that it is open and patients are coming to the doorsteps of hospital, we are also seeing that patients who didn't have much of allergic rhinitis symptoms, maybe about 3-4 years, and they had not come to the hospital. Once they got COVID, they are actually coming to the hospital, and they say that again these sort of symptoms which were, this thing were of less, has again started coming. So these are just anecdotal experience that I'm telling. And of course, we are still learning from the disease, and maybe they will have some publications on this. We have got a post-COVID also registry, which is also capturing all these events that is coming. So maybe in some days' time, we will have some also definite reports. But yes, we do find that patients do post-COVID, they do just complain of nasal problem, and especially smell related problems.
I think there are no more questions also. One simple question from me, sir. That means we are seeing most of the patients with post-viral airway hyperresponsiveness. So when your patients are getting viral infection, some UITI, and after that they are complaining of persistent cough. So what is your experience of this Bellastin molecule in such kind of post-viral airway hyperresponsive type of cough?
So I think Bellastin has a widespread antihistaminic role, in fact. So first of all, its onset is very quick. Within an hour, I think you have the onset of action, and the action lasts for more than 24 hours. In fact, it's for 26 hours, and the half-life remains still about 14 to 15 hours. So I think this is going to cause, I think, relief of symptoms for a prolonged period of time. So and since it is not at all metabolized through I think liver, I don't find much of drug-to-drug interaction, except the common ones like erythromycin or ketoconazole. There is a mention of that it should not be taken with the grapefruit. So these are something that you should not. Otherwise, Bellastin we are experiencing, and we are also giving it to patients. And actually, especially when there is a, I also mentioned about allergic march in my talk, and I see that patients who have got asthma, allergic rhinitis, and also itching sometimes. So in these patients, I think I do use Bellastin actually solely because it has got much more role in these patients than any other, I think, cohorts of allergic rhinitis patients. So yes, post-viral, we do see hyperreactive, so you should rule out if it's infective allergic rhinitis, as I've done the classification of etiology, and it can be used. I mean, we have experience. We have very good experience with Bellastin in this condition. So one more thing that I want to know, and which I think many pulmonologists do not practice, and I would like to ask you, in fact, that even I was not also very much would like to do what was skin prick test, but in the patients who have asthma with coexisting allergic rhinitis, it is always better to do a skin prick test. There are some problems of getting standardized antigens, but if you selectively choose your patients and do skin prick tests, and because the best treatment is avoidance of allergen, which is the foremost, and the environmental correction of these patients with allergic rhinitis is very important. I think more and more pulmonologists should go for skin prick tests for such patients who have got coexisting asthma with allergic rhinitis, because it shows also very good results. And of course, dust mites and all are there. So, often patient comes to you and he would ask you that to which he is allergic to. And then to answer this question, you have to have some substantiation in the form of skin prick test, and you do this, and at least sensitize him about his environmental correction and see if it is there. I have seen skin prick tests I have done, and I have seen the report positive for Parthenium grass. And when I asked that, do you have this grass around your house? And I think 8 out of 10 then patient will tell me yes. So even the simple exercise for these patients, because we would get patients of allergic rhinitis who are quite severe, who have been already actually given intravenous corticosteroids and antihistamines, and still they're not getting relief, or they take it only for some times and then stop it. So I think it is quite wiser to do skin prick test, allergy skin prick test, to see if they are to us what allergens they are allergic to, and to just tell them to avoid those allergens if possible, and to advise about environmental correction of the surroundings at home and also at their workplace.
Yes, sir. I think there are no more questions there. So I think with permission of Abhishek Gupta sir, we can conclude today's session. If any questions are there, can just text me. Yes, sir. There are any questions again?
No, sir. No question more, sir.
So I think with a lot of thanks, we can conclude the sessions.
So
it is such an
Abhishek,
on.
yeah. So yes, Abhishek, I would like to ask you only this: that do we have any study of combining montelukast with Bellastin?
Yes, sir. We have for RA comparison, sir, means like RA based on ARIA guidelines. The 10 points are there, sir, in which levofetrevin, fetravin, fexofenadine, and Bellastin are compared, sir. Out of that, sir, Bellastin scores 10 out of 10, sir, against all three antihistamines, sir.
Yeah, so it's got very good attributes of ideal antihistamines as has been put, and but it has come now, and only word of caution is that it should be given empty stomach. It should be given 1 hour, I think, before meals, or 2 hours after meals. So because food can hinder its absorption, so this is the one that we should learn, because it's a new molecule. So I think we can make this fact aware to everybody. Thank you.
Thank you, sir.
I think there are no more questions. So it is time to conclude today's interesting session. So it is a great honor for me to get the opportunity to thank you all the dignitaries. I would love to express my gratitude to all the esteemed dignitaries of the webinar for the presence and the contribution in this webinar. I extend my gratitude to our honorable chief guest, Dr. Rajesh Swarnakar sir, to take out his time in his busy schedule to grace the event. And I must also thank the organizing team also. And thank you everyone once again.
Thank you.
Thank you.
Thank you, sir. Thank you, Rajesh sir. Thank you, Avinash sir.
Thank you. Thank you very much.
Thank you for your valuable time, sir.
Thank you.
Thank you for a happy weekend, sir.
Recording stopped.